And now I invite Dr. Maya TJ, who is a glaucoma consultant in Little Flower Hospital, Angamali. She'll be discussing Seeing the Unseen, Clinical Clues and Diagnostic Strategies. Over to you, Maya.
I'll be presenting on Seeing the Unseen, Clinical Clues and Diagnostic Strategies of Normal Tension Glaucoma. I'll be explaining in this format. Normal tension glaucoma has all the features of a primary open-angle glaucoma with optic nerve head cupping, corresponding visual field loss, but mean intraocular pressure consistently equal to or less than 21 millimeters of mercury. Take a careful proper history. Patient usually presents at an elderly age. If the patient is presenting at an age less than 50 years with atypical findings, we have to think of the masquerades of normal tension glaucoma. Ask for a history of vasospastic diseases like migraine, Raynaud's phenomenon, autoimmune diseases like multiple sclerosis, sarcoidosis, and if the patient is taking a night dose of hypertensive, you can expect to have a nocturnal hypotension. You can ask the history for that. History of previous retinal vascular occlusion should also be made out, as this can cause one-time damage to the optic nerve head, which could look similar to that of a glaucomatous optic disc. Also, ask for history of glaucoma and blindness in the family, as you can get an idea about the progression of the disease. Carefully probe the patient's history for possibly elevated intraocular pressure in their past, like history of ocular trauma, hypema, prior steroid use, or prior vitreoretinal surgery. History of severe hypotension or shock. Ask the patient for history of surgery, trauma, sepsis, prolonged ICU admissions, or any need for blood transfusion. Obstructive sleep apnea is also hypothesized to alter optic nerve perfusion pressure. So you can ask for history of snoring at night with daytime somnolence. Ask whether patient does yoga positions which need to be held for extended periods that position the eye below the level of the body. It could also reduce the ocular perfusion pressure. So clinically, the patient can present as an asymptomatic non-progressive disease, which is usually picked up by an ophthalmologist during routine checkup, or as a moderate to advanced disease. Even in moderate diseases, if it is unilateral, patient may remain asymptomatic with negative scotoma. Patient may have reduced contrast sensitivity and glare, or the patient can present with an advanced disease who appreciates the visual field loss. Like primary open-angle glaucoma, these patients are asymptomatic until late in the disease course. Unfortunately, these patients are undetected by intraocular pressure testing that may pick up patients with early primary open-angle glaucoma. But the paracentral field loss may make the patient symptomatic earlier. Coming to clinical features, you can get a relative apparent pupillary defect, though it may not be present in the early or asymmetrical diseases. Color vision is usually preserved except in advanced disease. Reduced central corneal thickness is associated with progression risk. Do a proper slit lamp examination to rule out the secondary causes, like you can find intermittent peripheral angiotensinic in cases of previous history of uveitis. You can find Kuchenberg spindle or St. Mary's line. Thus, you can come to a diagnosis of pigment dispersion syndrome. Then, by definition, intraocular pressure is in normal range, but intraocular pressures are still important. In eyes with asymmetric disease, there is more damage in the eye with higher pressure. The collaborative normal tension glaucoma study demonstrated that lowering the intraocular pressure is effective in decreasing the risk of progression. In the Baltimore eye study, half of the primary open-angle glaucoma patients had intraocular pressures less than 21 millimeters of mercury at initial examination itself. Then, with apparently controlled intraocular pressures measured in the office hours, you can go for an IOP phasing, which can help demonstrate an IOP mechanism in patients with rapidly progressive disease. Usually, they have a more than normal diurnal variation, which has a peak at early morning. Coming to gonioscopy, which is essential in all glaucoma patients, it helps to determine an open iridocorneal angle status and to exclude secondary glaucoma causes. You can find intermittent angle closures, old pigment dispersion syndrome. This figure, the first one shows increased pigmentation in the reduced pigmentation in the superior angle compared to the reduced pigmentation in the inferior angle. That is, there is reversal of pigment dispersion. Usually, you have more pigmentation in the inferior angle compared to the superior one. But in a burned out pigment dispersion syndrome, you can find the reversal. Then careful optic nerve examination should be done. Usually, More frequently, you can get a focal notch of neuroretinal rim than you find in the higher pressure glaucomas. Other glaucoma findings are also found, like enlargement of the cup to disc ratio, which can be focal notch, retinal nerve fiber layer defects, or concentric defects like excavation or senile sclerotic disc. Disc pallor occurs in advanced disease. The first two pictures shows inferior notch and inferior neuroretinal rim thinning, and the third one shows a superior notch, neuroretinal NRR notch, with a disc hemorrhage with a slit-like RNFL defect. Then disc hemorrhages are more frequent in normal tension glaucoma, otherwise called dance hemorrhages. They are typically small flame-shaped hemorrhages at the disc margin in superior or inferior quadrant. It is often interpreted as a marker of disease progression, which you can find in the first picture. You can get an evident disc hemorrhage, and in the second picture, you have to look carefully for a disc hemorrhage, which is very subtle. So in such situations, serial fundoscopic or disc photographs will help you. This first picture shows a normal, second picture shows a disc hemorrhage, which when compared to the previous one, you can pick it up easily. Then you should do a careful optic nerve examination to rule out the congenital optic nerve diseases, optic pit or optic nerve drusen. This picture shows an optic nerve drusen. Then coming to optical coherence tomography, here in the fundus photo you can find the temporal thinning, which is picked up by the OCT. Then you can find the RNFL defects also in the RNFL deviation map, and you can find a corresponding visual field defect involving the center. Visual fields, when compared to other glaucomas, they are more frequently steeper, deeper, and closer to fixation, as you can find in the picture given above. Is more localized than in primary open-angle glaucoma. Then usually the superior hemifield is more frequently affected. In this picture, you can see an inferior nerve fiber, inferior neuroretinal rim thinning with a corresponding superior hemifield defect. Then the red flags include younger age or patients without a family history, rapid progression, unilateral disease, associated features like proptosis, other neurological symptoms, atypical findings like disc pallor. In these patients, you have to go for an MRI to evaluate the potential compressive lesion and to assess for ischemic optic neuropathy. Other testing measures are diurnal variation, 24-hour monitoring, BP monitoring, blood tests to rule out the secondary causes like vitamin B12. Proper cardiac evaluation should be done. Then many other features can be misdiagnosed as NTZ, like physiological disc cupping, myopic fundus, disc drusen, optic dystrophy, and other toxic and inflammatory causes also. So this one is a non-arthritic ischemic optic neuropathy, which is a remote one. In this, you can find the visual field defects and the corresponding superior thinning in the OCT, but there is no cupping. More pallor is present in the superior part of the disc, which corresponds to the non-arthritic ischemic optic neuropathy. Then you have to find, it is a diagnosis of exclusion. You should exclude all other types of glaucomas. So when all the features consistent with glaucoma, along with intraocular pressure less than or equal to 21 millimeters of mercury, then you have to rule out the secondary causes, and if any atypical findings are present, then you have to investigate further. You have to image the patient. Never be hesitant to image a patient if you find an atypical findings in glaucoma.